Welcome to the next in the KDIGO Genetics and CKD Webinar Series. Today's episode is episode 6, Challenges to Implementing Optimal Genetic Testing for Patients with Kidney Disease. Note that questions have been submitted in the registration process, and you can also type in your questions using the chat feature in today's webinar interface. We'll get to as many questions as time allows, and questions that we don't have time for will be followed up individually. Our speakers today are Dr. Albertien van Eerde, University Medical Center Utrecht in the Netherlands, and Dr. Hila Milo Rasouly, Columbia University Irving Medical Center in the United States. At this time, I'll turn the webinar over to Hila. Go ahead.
Good morning, good afternoon, good evening. As introduced, I'm Hila, and we're going to discuss together with Albertien the challenges to implementing optimal genetic testing for patients with kidney disease, really discussing the logistical questions around securing genetic care for patients with kidney diseases. We do not have any disclosures. So as an introduction, we really want to highlight the fact that each country and state has different regulation and approaches to genetic testing, and therefore there is no one optimal implementation approach for genetic testing. Each individual will have to figure out where they live, what are the situation in their places, and make it from there. We will highlight the questions that should be addressed when utilizing genetic testing as a diagnostic tool for patients with kidney diseases, and provide few examples of current approaches we are aware of. Obviously, there are many more that we are just not aware of. Overall, this webinar is a continuation of prior webinars in the series that discussed who should be offered genetic testing and which testing to offer. And so we are not going to discuss these questions. We chose here a quote to kind of differentiate what we are going to do compared to prior webinars. So you probably know this quote: there are no knowns and there are things we know that we know. So this really what we are trying to do in the prior webinars. There are no unknowns. That is to say, there are things that we now know that we don't know. And that's the goal of this webinar, to help you know more of the things you don't know and you should begin knowing, and reduce the unknowns, so the things we don't know that we don't know. So the first question that each physician would ask themselves when they see a patient who may benefit from genetic testing is, what should I do? And really there are two major routes. The first is you can yourself provide your patient with pre-test genetic counseling, choose the appropriate genetic testing, and order it if applicable. Or if you don't feel comfortable doing one or all of these steps, you can refer your patient to someone who can do all of those. In all cases, your responsibility as the nephrologist caring for this patient is to make sure that proper pre and post genetic counseling was provided to your patient. But the who is providing these may depend on the indication. It may depend on your patient. So the first step towards securing genetic care for patients is obviously to identify those who may have a genetic form of kidney disease and either offer them this pre-genetic testing counseling or refer them. So for the most common genetic diseases like Alport or ADPKD, the expectation today is that most nephrologists can recognize the clinical features, provide pre-test counseling, know which test to order and how to communicate the results, and refer, if needed, family members for counseling. However, for all the other genetic kidney diseases, it can be much more complex, which was discussed in prior webinars. And the decision on who should be offered testing and which testing to offer is complex. Nevertheless, even though it's complex, all nephrologists are expected to be aware of the minimal indications for testing to be able to identify these patients who should be offered genetic testing, because really, if not, the nephrologists become a barrier to genetic testing. So we try to delineate these 4 steps for the diagnosis of a genetic form of kidney disease. And the first one, as we just mentioned, is the identification of a patient who may have a genetic form of kidney disease. And as I just mentioned, all nephrologists need to identify those patients, to be able to identify those patients. The second step is the pre-test genetic counseling and the ordering of a genetic test. And this really should be done by someone who feels comfortable explaining the test options, explain the benefits and the limitations of the different tests, and choose the correct test for this patient. The third step is the post-test genetic counseling, the return of results and the management. And again, it should be done by individuals who can explain the result and either manage the follow-up care or refer patients. And it may be done by two different individuals. Someone may return the result and then refer to someone else for the management. And that's the fourth step, the clinical management resulting from the genetic diagnosis. So maybe change of medications, family planning, advising family members. And again, that might be done by multiple different providers. And it depends a lot on the diagnosis and the type of care needed. So the different people who are involved in genetic diagnosis, this is what we are referring to a multidisciplinary aspect of genetic testing and diagnosis. And the professionals who are involved differ from country to country. And we are just giving here a list of the professionals we know about. There might be others that we left out, and it's not intentional. So first, we highlighted clinical geneticists, MDs with a specialization in medical genetics, and you can see an asterisk because it's not an established specialty in all countries, or sometimes it's a high shortage, and therefore not really available for you. A sub-specialization of clinical genetics is clinical geneticist with a specialization in genetic kidney diseases, and these are even more rare. Then there are genetic counselors, again, not available in all countries. Those are professionals with a master in genetic counseling. And molecular geneticists are either PhDs or MDs, often working in laboratories, but sometimes have the capacity to also counsel patients. Nephrologist, with a subset of nephrologists having a specialization in genetic kidney diseases. Again, more common in some countries than others. Physician assistants, which in some countries are involved in the ordering and return of results and acting more like genetic counselors. Similarly, there are some nurses who are now have roles very similar to genetic counselors. And there are research human geneticists who can be involved in mostly in the interpretation of the results.
The question about how patients can be referred for nephrogenetic evaluation, it differs. In Europe, many countries, I already mentioned that, many countries have kidney genetic expert centers, but there's also countries that don't. Within the EU, there's official regulations that samples and or patients can travel, but oftentimes there are barriers for that. For instance, there's paperwork involved where you have to prove you cannot get the care in your own country. My experience is that it doesn't happen that often, but it can. There's also a system for EU recognition for kidney expert centers. The EU has devised a big scheme for care for people with rare disorders, in the sense that they designated the need for European reference networks. There's 24 of them, and one is for rare kidney disease. And that resulted in national expert centers needing an official accreditation from their own country in order to enter the European reference network. In Orphanet, you can also search for the accredited expert centers. And in general, if you just want to know how to find a clinical geneticist or something along those lines, within a European country, you can look at the site of the European Society for Human Genetics, and there's a European Relations tab with a link that became rather long, but you can find it this way. So Hila, over to you for the situation in the US.
Yeah, so in the United States, it's not as organized as in Europe, not yet, at least. So we do not have this federal level organization of which genetic clinics are kidney genetic clinics. However, there are more and more kidney genetic clinics that have opened across the United States. And with the pandemic, there are more and more telemedicine options that have been open in each one of these clinics, allowing for patients who do not live in close proximity of the clinics to see these experts. However, recently the licensure issues have been brought back in, so not all physicians or genetic counselors can see patients from any state. And so these are things to figure out as you are going, whether there is a kidney genetic clinic in your state already. If yes, it's really easy to refer patients there. And if not, it might be a little bit more complicated, but yet possible. The National Society of Genetic Counselors, the NSGC in the US, has a website that allows to search for a genetic counselor. And you can search actually by subspecialties of genetic counselors. And one of the subspecialties there is nephrology. So you can search by state, or you can search in general across the United States and Canada in this website. And it will provide you which genetic counselors have self-identified themselves as specialized in nephrology. So again, it's not as structured as in Europe yet, but it is in the way of getting more and more specialists with knowledge specifically in kidney genetics. So I thought I would share with you just our kidney genetic clinic. It's just one example because I'm the presenter. I'm sharing the Colombia one, but obviously there are others that have other structured across, and some have already published papers describing their clinic. So if you're interested, or if you find out that there is a clinic in your state and you want to know more about, they may have already published a paper describing their system for referral. At Columbia, our kidney genetic clinical team is organized with just nephrologists and genetic counselors, and you will see it's very different from what Albertien will present in the next slide for her center. The service is really just two services as showed in red. One is genetic counseling consults, which are offered by genetic counselors only, who can provide pre- and post-genetic test counseling, assist on genetic test selection, genetic test result interpretation, and help with cascade screening or genetic testing for at-risk family members, or any other need really if it's family planning of other types. The other type of consult that we have in red is a comprehensive genetic visit, which includes our nephrologists who are specialized in genetic forms of kidney diseases, and they would do a full examination, even though today even the full examination can be done in telemedicine, but really also adding onto the visit the attempt to identify which clinical diagnosis the patient has. So there are three paths of referral for these two types of consultations, and they are shown in purple here. Physician internally at Columbia, nephrologist or others can refer directly through our medical record or by email to our genetic counselors. External MDs can also refer either through our email or phone, or we have a web page where they can refer their patients. And patients can also refer themselves, what we call self-referral. They do not have to have a physician referring them to see us. That was our brief description, and I think it's interesting to compare it to what Albertien will present next.
Yes, thank you, Hila. So I'll be presenting our example, and really I want to stress this is not something that we designed. This is something that evolved from the existing hospital structure. Our referrals come from inside the expert center. They come from other hospitals. They can sometimes be referred by their GP on their own initiative, and they can be reevaluated or transition from pediatric to adult care within the expert center. So they come to us if there's a suspicion of a nephrogenetic disease, either in the index patient or in the family. They can enter via multiple routes, either via the clinical geneticist or via nephrology or pediatric nephrology, via OBGYN or via the pediatric urology, I'm sorry. And then if the triage is handled by the clinical geneticist, then we can go one step further in requesting additional data for the first visit, because we also have the infrastructure for requesting data from family members and consent forms, etc. For that, usually the other specialists don't do that for a first intake. Then we decide whether the patient should be fast-tracked, yes or no. That's based on whether there's a treatment decision waiting, so either a biopsy that might be avoided, or a related transplant, or the start of treatment, whether there would be pregnancy, or we also fast track patients that had an acute presentation of CKD 4 or 5 at a young age, so these young adults. Also, we think about whether it's a diagnostic question or whether it's more a cycle of life planning, a family planning like a question. Is it about follow-up or shared care or a combination of those? Sometimes we need one of our multidisciplinary meetings to discuss the best place for a patient, because we have several. So we have the colored clinics are the multidisciplinary clinics we have available. So there's a multidisciplinary clinic for pregnancy and kidney disease. So these are for the women with kidney disease that either want preconception advice or pregnancy follow-up. Then there's the clinical genetics and nephrology, so the adult renal genetics clinic. There is the pediatric renal genetics clinic, where I usually do the clinic with the pediatric nephrologist. Then there's the ciliopathy clinic with there's more emphasis on follow-up. So I'm the consulting there, and there's the pediatric nephrologist, the ophthalmologist, and a pediatrician and a dietitian. And then we also have the prenatal kidney ultrasound clinic for ladies that come in with a fetus that shows abnormalities in the kidneys in the pregnancy ultrasound. So, and then obviously we have our separate clinics where we can see patients. Obviously, you try to avoid seeing patients too many places too many times, but sometimes you do need two clinics. For instance, when there's a diagnosis of Alport syndrome in a young child, in a young boy, and the mother does have a phenotype, and also she wants to become pregnant again and wants to avoid having children with the same disease again, then you might need more than one of these clinics. Going to the next slide. So when necessary or in doubt, we discuss in our multidisciplinary meetings that I have a separate slide for to show you. We do additional testing, either genetic or more specialty based, and we give advice for family members. We discuss the result with the patient, and in case of a molecular diagnosis or a fuss established by one of the other specialists, then they always refer to the clinical geneticist for counseling of the finding. Also, I think important to mention that we have several social workers. So the social workers that are involved in nephrology and pediatric nephrology, they really they handle the chronic disease part and the starting replacement therapy part. But our social worker at the clinical genetics department is really keen on discussing pre-symptomatic genetic testing, for instance, in minors, options for talking through options for family planning or establishing a family, and also at the request of the patient, they can be seen by our social worker. So this this left bar, this is important. There's a lot of weird acronyms there, but basically it means that we are aware of that we try to have all patients that that are eligible to include them in registries, and I think that's important. So we have our own registry for patients that have genetic testing in our diagnostic lab, but we also contribute to the ERCnet registry. And we have a registry for outcomes of kidney disease in pregnancies, or outcomes of pregnancies in patients with kidney disease, I should say. And we don't have a 100% system where we get everybody in. So that's one of the things that we're really working on. This is one of the things that is important in terms of caring for patients with rare disease. That you make sure they're findable also for maybe future treatments or other things. So then the lowest part of the graph, it makes sense because it's not rocket science. So either they go back to the referring physician, or we follow them up within our pediatric center or in the adult center if they need, as I coined, a cycle of life care. They need to be at the OBGYN or clinical genetics somewhere. And in the end, if they transition to another phase, you can start at the top again. So how about those multidisciplinary meetings? There's a lot of words here and you don't need to remember, but one of the things that I wanted to point out is that we really see each other in multidisciplinary fashions quite often. So back to our questions. So one of the important questions is who can or does order a genetic test? This really depends on the country. So in some countries, legally, only clinical geneticists can order this type of tests. And it can even depend on the situation. So who can order a prenatal test or a pre-symptomatic test in minors or in pediatric cases can be a different specialist than somebody who's also allowed to do testing in adults. In the Netherlands, the rules are not so strict. The rule really says that if you're a doctor and you think you are competent, you can do this. But thinking you are competent there is written down. There's a guideline stating the things that you should be able to do. But there is, for instance, a line in pre-symptomatic genetic testing and prenatal testing. So that is something that nephrologists or pediatric nephrologists really are not allowed to do. In some countries, any physician can order a test. In some countries, direct-to-consumer genetic testing is becoming increasingly available and also used. And in others, genetic testing is only available through research cohorts or through international collaboration, simply because the infrastructure and maybe the economic level in the country doesn't allow yet for academic or commercial testing within the country. Also very important are there guidelines or laws in your country regulating this ordering of genetic testing? This is something you really need to be aware of and look up. The next question also pertains to genetic testing, but that's not who can or does order it, but also who decides actually which type of test is performed. So the different types of tests and the details of these types of results you can expect were discussed by Nina Knoers and Andrew Mallet in episode 4. But actually, who makes the decision of which technology is used? Is that the ordering physician? In that case, the ordering physician should also be aware of the benefits and limitations of different kind of lab tests, or is it the laboratory performing the test? For instance, if I'm informed correctly, a few years ago, when in France, when ordering a genetic test, you are always in any country very much they like you very much to give a lot of phenotypic detail in your request. But if, as a nephrologist, you would send in a sample for genetic testing for FSGS, then the laboratory specialist would decide which genetic panel would be performed and whether or not it would be suitable, or also a deletion testing should be performed. In the Netherlands, in my country, the requesting physician has the responsibility to decide that. So, in this respect, even more important than who is allowed to do what and who is deciding what is the direct communication between the ordering clinician and the laboratory. You can reduce the risk of ordering the wrong test or misinterpreting a negative result. So this really goes to both the information you supply with regards to your patient phenotype, but also simply the communication you have around which type of test you should do and also how to interpret the result. There's also additional factors to be considered. For instance, does the test require a pre-authorization? And if yes, by whom? So is there a barrier, for instance, in centralized healthcare or by private health insurance? It's also important to consider the different tests costs. So for the tests that are available, what they cost and how they are covered and how they are paid for. Is it via health insurance or do patients need to pay themselves? And important is also the patient's circumstances. So is there a time constraint, for instance, because there's an early ongoing pregnancy, or if there's aversion to uncertainty? In the first case, you would do rapid, maybe broader than you would do if there's enough time. You would do rapid, broader testing, and if there's a case of aversion to uncertainty, you might start smaller, for instance. And that's the question of how to choose the laboratory performing a test. So let me begin by saying that oftentimes you don't have a choice, but even still, then you need to be aware of what kind of laboratory you're sending the sample to. And if you do have a choice, then it's better to make an informed choice. So one of the first things is this testing performed in an academic situation, maybe your own academic situation? Is it a commercial lab or maybe a research lab abroad? How much support can you receive from the lab? Hila also already alluded to that. Can the lab help you choosing the right test? Or maybe does the lab offer genetic consultations to you, the nephrologist? Do they have time for that, or make time for that, I should probably say? Does the lab itself offer genetic counseling to the patient? And probably, but I'm not so familiar with the commercial test results. There's probably also variation in how extensive their result writing is in terms of making it understandable for a patient. But an important question that is often not asked is, what does the lab do with the data? So is the lab sharing data on public databases? Does the patient get access to the raw data? What can you, as a requesting physician, do with the data? And these things change when you are moving along these axes of commercial versus academic versus your own academic laboratory. As an example, we have a protocol in place where the genetic panel tests are all run from whole exome sequencing data, and then we have a protocol in place where we kind of anonymize and pool the data and can look for variants in candidate genes. And if the patients do consent, we don't pool the data, and we can do additional testing. But this is all because the testing is performed in our own academic lab, and there's nobody else that has that's prohibiting us from analyzing the data. The last question that you would need to think about: what happens if there's a negative result? So if there's, would they offer additional analyses? Would they have additional costs, or would it be within the fee? I think those are probably the most important questions. Hila, you have more experience with the commercial type of testing.
Yeah, so I would like to add regarding the sharing data on public databases. It doesn't have to be the entire data. So one of the main resources that we have in clinical genetics to identify likely pathogenic and pathogenic variants is ClinVar. And ClinVar has now a list of all the laboratories that are sharing their results back to ClinVar to help others when doing diagnosis. And this is really the goal of having it publicly available. Who are the labs is to try and reinforce the importance of sharing. If you find a variant, and thanks to family segregation or others, you are giving it the label of likely pathogenic of pathogenic, it might not reach the same level of significance in an individual who doesn't have any family history. However, if this information about this other family is present in ClinVar, it can really change the diagnosis for your patient. So this sharing data is really, really important, even at the basis of when we reach a diagnosis. The level that Albertien discussed, it's kind of the next level is also important for research, and the importance of sharing the entire data is also our understanding that there is much more genetic variation than we thought there was in the world, and so there are a lot of variants that we have a really hard time knowing whether they are causing diseases or not, and sharing the data is an important tool we have to help us differentiate between benign and likely pathogenic variants. Regarding the lab offering additional analysis, I would add here, so not only definitely that there are laboratories, commercial laboratories in the US that would offer additional analysis for small fee, while others, you would have to redo the test from scratch, send a new sample, etc. But also there are cases where there is a VUS that is identified, and some labs will offer testing of family members to try to clarify whether this VUS is segregating with the disease in the family or not, while other labs do not do that. So it's also something to take into consideration. And finally, there is for positive cases, some labs offer free cascade testing for family members, while others don't. So these are kind of things to take into account when choosing a laboratory.
Yeah, and I still I want to hop back once more to these public databases, because clearly Hila and I were thinking of different scenarios. One of the things that I was also thinking about, so there's definitely a positive side about sharing data, but especially when it's about sharing the whole exome sequencing data. In Europe, there's very strict privacy regulations, because obviously it's very privacy sensitive data. So this is one of the things that I meant when you're sending. So when you're sending a sample to a commercial laboratory that would, well, and now I'm exaggerating, but would do like the test for free, you really need to wonder what they're gaining, and they're gaining the access to the whole exome sequencing data of the patient. So it can be fine, and you can decide with the patient that is what you want, and maybe it's the only solution to get a result. But not being aware of that and having that patient data out there without the patient being aware of that, that would be one of the unknown unknowns that you would want to avoid. I think we can go to the next slide. And that's about the cost of genetic testing. We did mention some of these things already. There's so many differences here. So if you ask yourself, can my patient afford genetic testing? It really depends on where you are. In some countries, genetic testing is fully covered by the healthcare system. In some countries, genetic testing coverage by the health insurance requires filling out paperwork. Hila already mentioned that. In other countries, only a few test options are available, either because law or the insurance says so, or because the methodology really isn't available. Does genetic testing need to be pre-approved? We mentioned that, and if yes, what is needed from you, the nephrologist? Is it family history? Is it the clinical presentation? Is the potential impact on care? And Hila already mentioned that in the US, you need a letter. You oftentimes need a letter of medical necessity, but that probably differs a bit per insurance company. Hila, would you want to add anything on this?
Yeah, I just want to highlight, first of all, the letters of medical necessity shouldn't be seen as a barrier, hopefully. Nephrologists have templates they can utilize. From most labs are offering these templates, or they can ask for templates if it's not on the website. And it's asking you to write down things you already know. What is the family history of your patient? What is the clinical presentation? Why do you think it's important to test this patient? So the potential impact of care. There are more and more laboratories now that have financial aid options for patients. So patients in these cases would have to provide paperwork showing that they have an income under a certain amount, and then the test could be either free or very, very reduced to out of pocket. There are laboratories that are promising that the out-of-pocket will not be more than a certain amount. So these are things that just for you to know about. We would really hope that at this point, the cost of genetic testing would not be the barrier, the reason not to test. And our experience at Columbia is that we have quite a significant proportion of our patients who are on Medicare, Medicaid, and they get their testing done. We have patients without insurance and have their testing done. So we really hope that it will not be the barrier, with the idea that what Albertien just mentioned, that there is a reason that the laboratories obviously have an interest in these samples. So they have an interest of you sending these patients to get tested.
Yeah, and I come from a system where, from olden days, we are reluctant in giving the insurance companies too much information. So in my system, I would feel having to write the insurance company about the phenotype of a patient. That would already feel as the barrier. But so here you see excellent, well, not excellently, I wouldn't say that, but you really see how this works in different systems. If you try to sum it up, what might be negative impacts? So there might be a negative impact on insurability, potentially also for family members. There might be a negative impact on employment, or there might be psychological implications with regards to knowing, for instance, the prognosis of a disease you have, or the psychological implications of family history that really, I mean, the history itself doesn't change. The same family members were ill and maybe died at a younger age, but knowing it's all because of the same disease really can cause psychological impact in families, and also different family members coping with that differently. Positive impacts obviously are the impact on options for personalized treatment, the impact on options for family planning. In that respect, it's also important to make yourself aware of the options for prenatal testing and or PGT, so pre-implantation genetic testing, whether they are offered, whether they are legal at all in your country, and also whether they are offered for adult onset disease. Because that's also a distinction that's often made. Then impact on screening family members. And there is an important question, because we all know what to do when a patient is sitting in front of us in the clinic. But in genetics, the patient is hardly ever alone. So it really matters in your country what the official responsibilities are of the ordering physician towards the family members of these patients. And I'm going to turn over to Hila for this.
So yeah, we just wanted to spend a little bit of time on the legal duty to warn genetically at-risk relatives. And it's something that has been evolving over the past few years and is still kind of not clear in some places. So as a first example, the United States. In the United States, physicians and other healthcare providers have legal and ethical duties to make reasonable efforts to ensure that the genetically at-risk relatives of their patients are offered appropriate warnings. And so what does reasonable efforts mean? Is one, to warning their patients. So making sure that your patient knows that their family members are at risk. And second, encourage and assist their patients to provide these warnings to their relatives. And that's where really referring to genetic counselors might be very, very helpful, because genetic counselors have the training needed to help and assist patients to talk with their family members. Familial communication is often complex, and we know that not all family members are informed when there is a genetic disease identified in the family. And you can imagine that for some kidney diseases, it would be more important than others, but then you know, things are changing. We will talk about time a little bit later in our discussion today, but really this warning is important, and you need to have in writing a proof that you've made these reasonable efforts of making sure that your patients are aware that their family members are at risk, and help them talk with their family members. You do not have the right to talk to family members in the absence of a consent of your patient. So you cannot call your family member and let them know if your patient does not agree to do that.
The million-dollar question is, how can you improve your local or national situation? And I think in this respect, it's important to know, and there's a lot already great examples out there, that clinicians and patients can and need to lobby. And obviously this all starts with the awareness of the importance of these kind of things. You can lobby for guidelines, both for referral and testing. You can lobby for more clinician and patient genetics education. You can lobby or try to organize, obviously, a community, a network to discuss complicated cases. You can lobby for improvement of the coverage of the costs. And very important, you can lobby against genetic discrimination. I wanted to mention a few examples from my own experience. So with regards to guidelines, many times this it's per disease, it's too rare to have a real evidence-based trial-based guideline, but we did manage to write a working document with a best practice document in the Netherlands with, I already referred to it, genetics for nephrologists, detailing what a pre-test and post-test counseling should contain, what you should know about these tests, if you what you should know in order to feel comfortable with us requesting the testing yourself, but also referral indications and some introduction to genetics. So there's a working document on that. But there's recently a multidisciplinary guideline came out on kidney disease and pregnancy. And we contributed also some paragraphs on prenatal genetic testing, referral to a clinical geneticist in case of preconception counseling, and in those cases it often boils down to, do I believe the diagnosis that my patient is said to have? That's a very important question, and that's obviously referred to in the other webinars more extensively. Currently the Dutch Genetics Association is working on a document with regards to mainstreaming, which is the word that is used for genetic tests that are requested by other than clinical geneticists in the Netherlands. So the document would again give guidance on, as an organ specialist, what you should know in order to request a test yourself, with the idea that as we know more and more, the indications for genetic testing will grow even more, and then the clinical geneticists wouldn't even be able to request them all themselves. Many countries have laws against genetic discrimination, but they all differ. In the Netherlands, for instance, below a certain amount of money for life insurance, you are not allowed to ask for family history or the results of DNA testing. And Hila, maybe you can elaborate a bit on the US situation.
Yeah, so in the United States, there is a law called GINA, which was passed under Bush, and really protects against genetic discrimination for healthcare. So the health insurance cannot ask for family history or genetic results unless very specific categories. So in the military, they are allowed to use it. And if you are an employer of less than 15 employees, you are allowed to ask for family information. The GINA law does not cover at all life insurance or disability insurance. So there is actually no law against genetic discrimination for life and disability insurances in the US.
Yeah, and for medical care, we have this basic insurance where that everybody is entitled to, and then if you want add-on like extra dental care or something or other packages, then they are allowed to ask, but not for the basic medical care package. So it differs again, and really you shouldn't see it as a loose thing, but really as a part of how the whole system is organized.
Right. But I think going back to the lobbying, obviously this law would have never happened or passed without really strong lobbying from people in the rare genetics community.
We also thought to discuss with you the importance of awareness of time, because time is very important in nephogenetics. And why is this? It's because the organization needs to keep its services up to date with regards to disease knowledge, which keeps changing, testing methodology that changes basically every time you blink an eye, variant interpretation, but also patient history, patient needs and preferences, and family history, because families families always change, and only discussing the patient history, the needs and preferences, and the family history at the first intake is not enough. It's important to make sure it's up to date, and that you update it every once in a while. The medical record, the electronic medical records we have these days do give options for this. For instance, you might think of the medical history in many medical records that is copied again at the top of the patient note. When you see the patient again, if you make sure that in the medical history the family history is mentioned, and when that family history was taken, and also not only the ages but also the birth years of the children, then you actually know how the family involves, and you know what's the right time to ask whether the children are already thinking about having children, for instance, in an ADPKD family. It's also important to check who is responsible for variance reinterpretation. So, and oftentimes there's not an infrastructure to where you would get another report if a variant was reinterpreted. So you need to be able to, you need to every once in a while go back if there was a variant of unknown significance in a patient, whether it might be reinterpreted to be a diagnosis, or whether another genetic test would be indicated in the patient because the differential diagnosis might have changed. I'll mention a few case examples illustrating the impact of time, really from my personal experience. We had a couple in our clinic who had their firstborn die of a likely, at that point, new syndromal nephrotic syndrome. And they did have genetic panel testing, but they decided against a whole exome sequencing because terminating a pregnancy and or meddling with a pregnancy in case of prenatal genetic testing was against their religious beliefs. These patients were extensively counseled, this couple was extensively counseled about this, and they came back to the hospital when in the second pregnancy it turned out that also the second child was affected with this severe syndrome. And then that was at the time that we had just started our pediatric or neonatal intensive care fast track whole exome sequencing, and they were actually the first patients to go in because they at that point well, not changed their mind, but changed to the effect that they didn't want to go through this a third time. So then they did consent to whole exome sequencing, and we did also did the sharing analysis with the DNA of the firstborn. We managed to find the causative variant in the new gene, and managed to have that be allowed for a PGT, so pre-implantation genetic testing. And that took a while. It always takes a while, but especially because of COVID, the waiting became longer. And then in the end, this couple became pregnant, conceived naturally, and they had prenatal diagnostic testing, so a chorion villus sampling, and luckily the third child wasn't affected. So they changed from having not wanting to do whole exome sequencing to actually doing prenatal genetic testing simply because of the things they went through and the things they experienced. So this is one of the examples. Another couple came to us in, I would say, like the second stage of genetic counseling. So they were counseled elsewhere earlier before, and for AD-PKD, PKD1 went into a pre-implantation genetic diagnostic trajectory, and it didn't work within the allowed number of cycles, because you're allowed three cycles of PGT in the Netherlands. So they didn't have a child and weren't pregnant. And then they conceived naturally, but really they came to us requesting prenatal diagnostics, which we sometimes do in the Netherlands for PKD1, but not often. It's also not requested very often. And after counseling, it really turned out that they had invested so much in the PGT procedure, which is very, very intensive, that it was more the feeling that they would feel guilty of not doing prenatal diagnostics, which is by itself really a different procedure with a different endpoint. They felt guilty to not do that. And in the end, our social worker and we discussed with them, and in the end, they ended up feeling best with not doing prenatal genetic testing and accepting the risk as is. The third case I wanted to mention is a couple of at risk of a child with INF2 FSGS. The variant was discovered because of a progressive kidney disease in the father. At that point, he wasn't that much bothered by it. And they accepted the risk for their firstborn. But then when it came to going for a second child, at that point his kidney disease had progressed and he was going towards transplantation, and seeing that, so having the life event of what the kidney disease does to you made them choose for PGT trajectory for their second child. So these are all illustrations of what time can do in terms of patient needs. But the other things that we mentioned are equally important. So, for instance, in methodology and in testing. So, in summary, we showed you that this is a very multidisciplinary field. There's different professionals involved depending on the country and the clinic. As a nephrologist, you need to be aware of the existing organization of genetics in nephrology and genetic tests, but also differential diagnoses and the needs of patients can change over time. And there's a growing expectation that nephrologists will meet or need to meet minimal competencies in genetics. And with that, I'd like to switch to the acknowledgements. And in this webinar, Hila and I discussed this is really important because we told you about the multidisciplinary professionals, but also about the need for having multidisciplinary discussions and close interactions. And basically, it doesn't matter how you organize it, as long as the respective knowledge and the respect is available to you, and you know where to find it, and you know how to route your patient. And in our centers, we work closely together with nephrologists. In my case, we have a clinical genetics department, and I mentioned the full staff because there's 28 others out there that make it possible that I can really specialize in nephrogenetics, which I realize is a rare commodity. With that, I'd like to thank you for your attention, and I think we'll go to questions.
Okay, thank you very much. This is the moderator just jumping in. If you have additional questions, please type those in. We do have a lot of questions submitted already, so we'll just have time for a few. Go ahead, Hila.
Okay, so we're now going to transition to the Q&A section. Albertine, you mentioned earlier that there is a certificate for kidney genetics in Europe. Could you elaborate a little bit more about it?
Yes, I can, although I'm not organizing staff, although I do contribute. I think it should be a bit broader. It's rare kidney genetics, so it's not rare kidney disease, so not only genetic disease, but it's a 3-year program hosted by ERCnet. They coined it ERCeducation, I think, where people follow, so nephrologists, pediatric nephrologists, and in our case also clinical geneticists follow a 3-year program of webinars with exam questions following, and e-learning and e-cases. And after that, they get a diploma that they follow this curriculum. You can find it all on the ERCnet website, ercnet.org. I already mentioned it in the presentation, and it's very clearly established. And the nice thing about the webinars is that they are all available online to look back, so you can really look up per topic what you would like to see.
That's great. So hopefully they are going to fill the gap for this middle group in our triangle.
That's the idea. Yeah, that's the idea. So Hila, how do you guys arrange for patients that have clearly have a genetic disease, but where you don't find a genetic diagnosis?
So I think at this point it's really in the post result genetic counseling session that the limitations of genetic testing today are discussed, and there is a recommendation to come back, in a few years. I don't think that we have at this point a very structured way of telling them, come back exactly in 5 years at such dates. Usually calendars are for 6 months, but we do try to highlight in the letters, which are a big part, I think, in the organization of clinical genetics, and sometimes different from other specialties, that the letters are longer and really talking to the patients to try to make sure that the patients have control over their own health, to understand what was discussed. And the same letter is provided also back to the referring nephrologist, who would hopefully refer patients. We are also at Columbia, we have a large biobank that we're doing research on. So we are always inviting our patients to become research participants. And most of them are interested, and they do consent for it. However, research is very different from clinical studies. So not having a result on research doesn't mean that a similar clinical test would be negative. So we really try to emphasize that participating in research doesn't mean that they should not follow up with us in a few years. So thank you very much. That's all the time we have today. We hope you enjoyed and learned and took some notes of questions that you may ask your colleagues around you. Hopefully it was useful. Thank you again.
Bye.
On behalf of our audience, I'd like to thank our presenters for the great presentation today. As a reminder, we will follow up individually with questions that we did not have time for today. This webinar has been supported by an unrestricted educational grant from Natera. Thank you very much for attending. At this time, you may now disconnect.